Hello, I'm Nathalie Costedoat-Chalumeau from Paris, and I will speak about hydroxychloroquine, blood levels, and adherence treatment. So I have no specific conflict of interest. A patient with an lupus should be on hydroxychloroquine because it prevents SLE flares, it protects against damage, including renal, diabetes, thrombotic events, dyslipidemia, and it has been shown to improve survival with several studies now. It also maybe it prevents congenital heart block. So it is recommended by all, and the Treat to Target, ACR, EULA, and the European Renal Association. And my friend, Fred Uccio, also says that that's a good reflect of how the patients are well treated, the percentage of patients on HEQ in a cohort. It is also highly recommended during pregnancy and lactation. Regarding side effects, the main one is this one, the severe ophthalmological toxicity, which is very rare with 1 out of 1,000 patients. You should never see that, providing you follow the recommendation to screen for ophthalmological toxicity. And you will stop the treatment way before the real clinical toxicity. You can also have discoloration on the skin, which is not so nice. That's why some patients will stop it. And you have cardiomyopathy and myopathy, which are quite rare, and I won't speak about it for the sake of time. So hydroxychloroquine has an excellent benefit-risk ratio in patients with lupus, and an additional benefit, its long half-life with the availability of its blood assay. You can measure it in the blood. And you will have levels that vary widely among individuals, as it's true also for many other drugs. We have measured HEQ levels in patients and some other teams also, and we found that mean blood levels range between 800 and 1,000 nanograms per milliliter in patients treated with 2 tablets a day. And we found that low levels are associated with higher SLE activity and are predictive of flares. We also know that very low levels, you can take the threshold you want, but when it's very low, it means that the patients are severely non-adherent, meaning they don't take their treatment at all or just from time to time. And it represents 7 to 29% of the patients, depending on the series. This leads us to adherence to treatment. So this is defined by the WHO as the degree to which the person's behavior corresponds with the agreed recommendations from a healthcare provider. So adherence is about treatment, but also to recommendations of diet, physical exercise, and non-smoking. And as you can guess, that's difficult for some patients. Evaluating non-adherence is very difficult. And if you look at the studies, the non-adherence ranges between 3 and 85%. And with such a wide range, you can guess that there are some issues. Indeed, it depends on the methods used. Subjective, like self-questionnaires, which underestimate non-adherence, especially severe, and objective, like rates of fulfilling prescription when you compare what is prescribed and what is collected in the pharmacy, and also drug levels, which can find out severe non-adherence. There are 2 patterns of non-adherence, indeed. One, which is the patient don't take anything, it's severe non-adherence, or just 1 tablet from time to time, and drug levels are perfect for that, or mild non-adherence, meaning you forget from time to time, and you need other methods to depist, to find out that. Here is an example of what a young patient is supposed to take for her lupus with some comorbidities. And of course, you can imagine how hard it is to take this 1 day, 2 days, 1 week, 1 month, 1 year. We have a very nice study on non-adherence. This one was on pharmacy refill information with more than 10,000 patients with lupus. And you can see that 85% of them were classified as non-adherent. And if you take all these patients, the overall mean proportion of they covered, meaning what they collected in the pharmacy, represented only 42% of what they should have collected. So you can see that's a huge problem. And here, to show you that there are many consequences and that can be a real issue for our patients, in this SLEEK cohort, we measured hydroxychloroquine blood levels at the beginning of the study at inclusion for incidental lupus in 660 patients. We found out that 7% were severely non-adherent. They did not take their treatment, and we know that it will increase over time. It was just the beginning. And that was associated with SLE flare in the next year, with early damage until 3 years, and with 5-year mortality. So just by measuring HEQ levels, you can discover a very severe non-adherence that you would not have known usually. And you can try to improve that and to see with your patient what can be done. So that's the main benefits of measuring HEQ in our patients. That's it. I hope you enjoyed this talk and are interested by non-adherence, and I'll tell you bye-bye.